And I want to take a moment just to welcome you all to our third annual Black History Month event. And our goal for this program here is just to provide some updates. Dr. Hartley Brown, Dr. Blue is back to kind of follow up on the presentation that they gave us last year and all the things that they talked about, access to treatments, the different treatments that's available, and why a lot of times the African American community is not taking advantage of those treatments. So we're going to get some follow-up. Hopefully we'll have some good conversation today. And what you can expect, we're going to have Dr. Brendan Blue is going to be presenting first, and then we'll have the opportunity to address any questions that you may have for Dr. Blue at that time. Feel free to drop some questions in the chat, or I don't think the chat is on this one, so in the Q&A box, and we can kind of address those once he's done with his presentation. Now, Dr. Blue is a busy man, and he's got to leave us a little early today. He's heading out somewhere to do some good work. So if you do have specific questions for him, please drop those in the Q&A box so we can get those addressed. And then we'll hear from Dr. Hartley Brown, and we'll have another opportunity for some Q&A. So I'll just start. Many of you know these wonderful doctors already, but I'm just going to give you a little bit of read a little bit of their bio there for those who may not be familiar with Dr. Brandon Blue. He's an assistant professor at the Moffitt Cancer Center in Tampa, Florida. His clinical interests include treatment of plasma cell disorders and the evaluations of patients pre and post bone marrow transplant. His research and interests include reducing health disparities and improving health outcomes for plasma cell dyscrasias. Dr. Blue recently completed a blood and marrow transplantation and cellular immunotherapy fellowship at Moffitt Cancer Center. Dr. Blue recently completed He completed an internal medicine registry in the Department of Medicine at Washington University School of Medicine in St. Louis, Missouri, and a hematology oncology fellowship in the Department of Medicine at the St. Louis University School of Medicine. He earned his MD at Meharry Medical College in Tennessee. Now, Dr. Monique Hartley Brown is an emerging leader in the field of multiple myeloma. She's an assistant physician at Harvard School of Medicine and assistant professor and medical oncologist who specializes in treating patients with multiple myeloma. She practices clinical care at the Jerome Leiper Multiple Myeloma Center at the Dana-Farber Cancer Institute. Multiple myeloma is an incurable cancer that affects Black Americans approximately twice more than Caucasians. Dr. Hartley Brown has written several publications and has been a clinical research investigator for numerous clinical studies that have contributed to the advancement of clinical care for patients with myeloma and other plasma cell dyscrasias. As a Black female physician, she's dedicated to ensuring that the care for the myeloma community is equitable and affords all patients with myeloma an optimal level of care, regardless of background, race, or socioeconomics. So without further ado, I want to turn the floor over to Dr. Blue. And like I said, if you do have questions as he's presenting, feel free to drop them in the Q&A box there. Dr. Blue, the floor is yours.
Thank you so much for that warm introduction. Like I said, everyone, I am Dr. Brandon Blue. I am just some humble servant, just here to educate folks. I want this to be interactive, so if people have questions, please put them in the Q&A. I'll be more than happy to answer any questions. But I do have some updates, so I'm going to share some slides with you just because I want to make sure that people get a visual representation of exactly kind of some of the stuff. I'm still going to talk, but I also want to make sure that people, there's some people who are audio learners, some people who are visual learners. So I just want to make sure that people actually have a good idea of exactly what we're talking about here. Okay, so let me just start this. Okay. Perfect. All right. As I mentioned, I'm at Moffitt Cancer Center in Tampa, Florida. So I'm just going to go through some quick things about updates in myeloma. And the reason why this is important is because The people who are on this call may have had myeloma for 5 years, 10 years, 20 years, but some of the things that were true when you were first diagnosed with myeloma may not be true now. Okay. And I want to just make sure that people understand some of these updates. So, as people understand, multiple myeloma has been a disease that has been unfortunately affecting several organs. And some of those organs include typically the bone marrow, where we have bone marrow involvement of this disease. However, the kidneys can unfortunately be involved, and people can unfortunately develop bone lesions. All right. For a long period of time, they were called the CRAB criteria, meaning high calcium, renal dysfunction, anemia, and and bone lytic lesions. However, recently, what we learned is that there's actually been other criteria that makes people have multiple myeloma in addition to some of these CRAB criteria. So you might say, hey, I never had bone lesions or I never had kidney disorders, but I still have multiple myeloma. And the reason for that is that you may have some of these newer criteria that involve basically the bone marrow being more than 60% involved, or the ratio of what we call those kappas and lambdas to be at least over 100 to 1. Okay. And so just know that these are new updates, and those things may not have been true when you were diagnosed with multiple myeloma. But the goal of myeloma still has not changed. The goal of myeloma is to make sure that people get deep and durable responses. But one of the things that has been new, that is an update, is something called MRD negativity. Again, this is something that was not available several years ago. So the reason why this is important is that what we've learned about MRD negativity, meaning minimal residual disease, is that people who have this MRD negative status typically keeps their disease under control for a longer period of time. So when you talk to your doctor, an important update is asking about this MRD negative state, all right? And this is typically a test that's typically done on the bone marrow biopsy. So one of the things that the doctors may talk to you about is getting your blood numbers, meaning what they call an SPEP or an M spike under control, to get that kappa and lambda under control. But this is even a deeper dive trying to get the bone marrow MRD negative. And that's something that we know leads to longer periods of disease control. This is an important slide because this is basically lets everyone know that the deeper that your myeloma is controlled, typically the longer it will stay under control or in remission. So we always want as many people as possible to get into complete remissions as opposed to partial remission. And so just know the deeper down it is, the longer people's disease stays under control, or what we call this progression-free survival. Also, it's important for people to know, again, not knowing exactly when you were diagnosed with multiple myeloma, but some of the things that are relatively new that are updates are things that we look at called circulating tumor DNA. Sometimes it gets very difficult to try to figure out, is there any residual cancer left? And so just know that there's new techniques to try to figure out how much myeloma is left in the body. And I wanted people to just understand that these are things that may not have been around, again, when you were newly diagnosed, but we have new techniques to try to really do a deep dive to try to figure out how much cancer is left in the body. Some of the more traditional labs are still done, meaning that the doctors still check your kidney function. They still check your what we call the white blood cells or the red blood cells. That's still very important. People will continue to check your blood, as well as the urine is also typically checked. One of the things that's also important as well is doing that whole body PET scan, which is important. Some of the things that have also changed is trying to figure out if people have what we call high risk multiple myeloma or standard risk. Now, again, these are new classifications. And so what we've learned is that the genetic background or the genetic makeup of your myeloma sometimes helps us as the providers try to figure out what therapy might be the best for you. So for example, the people remember from science class, if you have 23 chromosomes from your mom, 23 chromosomes from your dad, you have 46. If you're a female, we would expect XX. If you're a male, we would expect XY. Now, sometimes a little piece of chromosomes can switch or what we call translocate. Now, some of those translocations, unfortunately, do lead to some of the resistance patterns or a little bit more aggressive phenotype for multiple myeloma. And you can see that if a piece of chromosome 4 and 14 translocate or switch spots, then we do see that those are high risk. And there's other ones that are listed here, but just know that might be something you want to bring up to your doctor is, do I have high risk multiple myeloma? Because again, that could determine how the doctor is treating your disease. And so it's just something that's very important. It should be monitored. The other thing to know is that there's so many new treatments for multiple myeloma that we're really, really excited that we're having this amount of options for people. Before and traditionally, there just weren't this many options. But you can see that as time continues to evolve, there's more and more therapies available that will let us lead to longer and longer periods of time to keep the disease under control. But I do want to kind of bring this back home a little bit because number one, this is Black History Month. Number two, this is something that I want to make sure that the minority people who are listening, so those folks who consider themselves to be in the Black and Brown communities, I do think it's important to talk about this next topic because this is very crucial. One of the things that's very standard in multiple myeloma is what they call an autologous stem cell transplant. And the question is should that still be used? What happens during this period of time is that people get higher doses of chemotherapy than they got during their traditional myeloma treatment. But with this higher dose of chemotherapy, it has led to longer periods of time of disease control. Okay. And this is very important because unfortunately, people of color, so people who are report themselves to be Black or African American, or people from the Hispanic community, unfortunately utilize this transplant less than other groups of people. However, myeloma is still the number one reason that people are getting this autologous stem cell transplant. So it's still very common, and it's something that traditionally there's been so many different studies that have shown that transplant has really helped people keep their cancer under control. Even in periods of time when you look at some of these new treatments, so there's so many new drugs that are available, especially for people when they're newly diagnosed with multiple myeloma. Just know that in that setting, transplant is still very commonly used. Okay. And so I just want people to understand this is something that has been tried and true and something that we hope that we don't have to use, I'll be honest, but it is something that is still considered what we call standard of care. Okay. Um, and so, this may be a little bit different other places, but the big thing about it is that there's no technical age limit, but we want to make sure that we help people more than hurt them. And if there's certain problems that you have that we know that giving you higher dose of chemotherapy could put you at risk, then we don't want to do that. And so you'll see here that we do look at what we call frailty. So for example, what that means is just because you're 70 doesn't mean that you can't get transplant because we all know people who might be 70 who look like they're 60. And we also know people who are 70 who look 90. And so it's not the age that matters, but it's how frail you are and how strong you are, and would you be able to handle something like this? Also, people may hear or talk about what we call secondary primary malignancies or getting second cancers. This is also very important because unfortunately what happens is that whenever the body opens the door for one type of cancer, other cancers do creep in, and that is super important for us to understand. What we're trying to do, especially at our center, and I'm sure other centers across the country, is we're trying to dethrone transplant. So we're trying to make transplant and higher doses of chemotherapy a thing of the past. So there is a clinical trial that is comparing this CAR T, which is the new therapy for myeloma, comparing it to transplant, and it will be looked at head to head. This is still in the early phase of research, so I don't have any updates for you at this moment. But just know we are looking at new ways of trying to figure out how do we keep people's disease under control. Another important update, again, this may not have been around when you we're newly diagnosed with multiple myeloma is what are we doing in the maintenance setting? So one of the things that we've learned is that if we keep people on maintenance, then typically their disease stays under control for a longer period of time. You may see doctors talk about should it be only for a short period of time or do we continue it indefinitely? And I wanted to just talk to people about some of the research that has been done. Now, I know a lot of people say, my cancer's under control. Why do I still need this treatment? Like, why do I need maintenance when my cancer is under control? It's because this is not a curable cancer. So what that means is regardless of how well you did after transplant or how well your numbers have now normalized, that we do know there will be at some point disease relapse. And so we have seen that if we keep people on maintenance, typically it's the lenalidomide or Revlimid, that we are able to keep people's disease under control. Okay, so just know that that's something that's very well studied. However, one of the things that we have recently learned is that maybe the lenalidomide or maintenance or Revlimid doesn't have to be the only medication. Okay, there's medications that we can use in addition to the lenalidomide that can likely improve the period of time that the disease is under control. There's medications such as bortezomib or the Velcade. Unfortunately, that does cause or has been associated with peripheral neuropathy, which is like numbness and tingling of the hands and toes. So your doctor may look at some of those, what we call high risk features, and may offer you some of these medications because we do know that there's a tendency, if people have a little bit more aggressive features or high risk disease, that they may respond better to some of these bortezomib or what we call proteasome inhibitor type medications during the maintenance setting. It's also important to know that bortezomib isn't the only one. Your doctor may use another medicine called carfilzomib. They sound very similar. It's because they're in the same class or they're in the same family. So just know that that's also an option. A lot of people on this call may be receiving another medication that is called daratumumab or Darzalex. That has also been shown to really help people when it comes to the maintenance setting. So just know that what used to be true, meaning everyone getting lenalidomide or Revlimid after transplant, has now really changed to this being, there's several options, and it's something that you can discuss with your doctor about because, again, the goal is to get people into that MRD negative state, and the addition of some of these extra medicines may help. I also wanted to just talk to people before my time is up about some of the progress that we've made when it comes to CAR T. So for those who may not understand CAR T, what happens is that we use the body's immune system to be able to fight off cancer. And with that, we've learned over the past roughly 4 years or so since it's been approved that we've been able to really help people when it comes to multiple myeloma. Not only do we have CAR T that's available, but that your doctor may be talking to you about something called bispecific T cell engagers, or they might just use the word BiTEs. But these also use the immune system to be able to fight off cancer. We were fortunate enough that in 2024, been able to use these medicines actually earlier. So instead of waiting till you relapse 4, 5, 6, 7 times, now we're able to use it in a second or third line option. And this is something that, again, is new. Again, this is something that was not true, again, years ago. So if your doctor is not up to date, you just might say, hey, I heard that CAR T was available for people even earlier because this may be an option for you. One of the things that we currently have right now is what we call a BCMA, meaning B cell maturating antigen, are the CAR T products that are currently approved. However, we know that multiple myeloma has multiple targets. And so one of the things that is under investigation right now is, can we use a different target for CAR T? And we're seeing some excellent responses. We're seeing that it works really well for people. And so what we're trying to figure out is, well, if these BCMA CAR Ts maybe stop working, can we give someone a second CAR T or maybe even a third? And so we want to keep changing the targets because this is how we someday will find the cure, because we're trying to get it to people more and more options to get their cancer under control. And so you'll see these letters, GPRC5D, they've really been able to use that target to be able to come up with a new CAR T that hopefully will be available in the future. One of the problems that happens with CAR T is, unfortunately, it's not something that we can give people right away. It's something that does take time. Typically, on average right now, it takes somewhere between 4 to 6 weeks from when we collect your T cells to when those cells are ready to be given. But we know that multiple myeloma, unfortunately, can grow in that 4 to 6 weeks. So that delay, unfortunately, does lead to more cancer in the body. So right now, what's being studied is, can we use faster manufacturing techniques to get these CAR T out to people within days? And again, this is still very investigational, but this is something that is hot off the press and something that we're really trying to use for people to try to see if we can get their cancer treatment to them in a timely manner. And so I just want people to know, in summary, MRD negativity, meaning the deepest dive that we have, the lowest amount of cancer detectable, is really what we consider now to be the new standard of care. And so I just want to open it up for any questions that may be there. I'll stop sharing my screen, and I'll be happy to answer any questions that people may have.
Awesome. Thank you, Dr. Blue. You always give us some good information there. We do have several questions that's in the chat box, and I'll just start from the very top. Have you heard of a clinical trial at MD Anderson for MM from China?
From China?
Mm-hmm.
Maybe there's if I knew a little bit more information, possibly, but there's several different trials across the country and international. I mean, everybody's trying to find the cure,
Mm-hmm.
so I'm sure MD Anderson has some. We have several at Moffitt. They have some at Harvard, which Dr. Hartley Brown is. So I don't know the details of that one, but for sure there's plenty of trials available.
Okay. And maybe the person that in there could just type in a little bit more information. We get a little further clarity there. So this person asked, what do you find to be the most common circumstances existing that prevent patients from receiving optimal treatment? Good question.
Yeah, it varies. I will say that what we do know, especially when it comes to the minority community, unfortunately, Black and Hispanic patients with myeloma are diagnosed at a younger age. And so when it is a younger age at diagnosis, there's different problems or issues that happen in your 50s and 60s that may not still be happening when you're 70. One of those things is working. So if you're past retirement age and you get diagnosed with cancer and the doctor needs you to be there once a week or twice a week, you say, "Oh, doc, I'm retired. I can come anytime." But if you're still working and have a family to feed, or maybe still have young children in the house, that's a much different time responsibility. So for sure, there's a lot of factors.
Yeah. Thank you for that. And it's different for every person,
Yeah.
particularly for that rural patient that maybe lives out a little bit further away. And like you said, has all of those things going on that they just can't stop. So this attendee says, I diagnosed with high-risk myeloma after finding elevated protein in my urine. Was there a point when I had smoldering myeloma, or did it just immediately go to active disease?
So again, without knowing the specifics of your specific situation, typically what happens is that everyone who has multiple myeloma at some point started out with a precursor condition known as monoclonal gammopathy of undetermined significance, or MGUS. Then after MGUS, then people do progress to smoldering, and then from smoldering to myeloma. The problem is that we typically aren't screened for MGUS. We typically aren't screened for smoldering. So we don't really know at what point the disease turns active. We typically find it when the disease is already very advanced. So without knowing the details of your specific case, it's hard to know without kind of looking at your blood work or urine tests.
Mm-hmm. And Dr. Blue, I want to go back. One of the first things that you were talking about was MRD testing and MRD
Uh,
negativity. We hear a lot about that these days. What what do we do? Because a lot of times patients are like, well, I haven't talked to my doctor about that. I want to talk to him about it, but what are you finding? What do doctors do? Let's just say the patient takes the test and they are MRD negative. Then what? Do they stop the maintenance therapy that you talked about, or how is that determined?
So, the MRD negativity is determined by the bone marrow biopsy, but that's tough because different people are at different levels in their myeloma journey, right? So, but the goal is to always try to get people to MRD negativity. So your doctor may use the fact that you're MRD positive to maybe add an additional medicine or maybe change something, you know what I mean? So that's how they might be using that information to determine your treatment. So again, that's also a difficult thing to kind of talk about because different people at different levels. But we use that to determine treatment for sure.
Mhm. And is it okay if a patient doesn't get or reach the MRD negative state? What does that mean? Because I know a lot of people, they get disappointed. Oh, I'm not MRD negative. But what does that
Yeah.
mean?
Yeah, I mean, again, the goal is to try to get as little cancer in your body as possible. So we always shoot for that. It's always better to shoot for something and then not get it than to not shoot for it at all. So, it happens. There's no treatment that is going to 100% do anything, but it is something that we shoot for. So, it's okay. And again, your doctor can always modify your treatment to try to get you to that MRD negative status.
Yeah, yeah. And I think that's important to say that, you may test this year and you may not be MRD negative, but 2 years down the road, 3 years down the road with further
Yep.
treatment, that may become the case there.
Yep. We probably got time for one more, Val.
Okay, all righty. I'll just go what numbers on the bone marrow biopsy report should you be looking at to find out if you have MRD negativity?
So it's not a numbers thing. So what happens is that it's a very special test. So in the typical bone marrow biopsy report, you'll see how many cancer cells you have. You'll see some of those what we call translocations or those genetic markers that we just talked about. But your doctor also will or should typically that won't show up in the routine report, but it'll show up in the MRD negative or positive report. So that's the separate test that should be ordered, again, to just find out if that MRD status has been achieved.
Yeah, awesome. And I got to sneak this one in, Dr. Blue. I know you got to go, but what can you tell us about the 1Q gain? And are there any new advancements in that abnormality? Because that's, considered one of the high risk um, cytogenetics there. What can you tell us about that?
Yeah. So I'll tell you that, that's a hot topic. One of the things that we're trying to figure out is that it's probably not just one adverse marker that dictates myeloma, but when people have more than one, I think unfortunately it just compounds. And so you'll hear people start to use the word double hit or triple hit myeloma, and that's where some of those markers may be taking place.
Mhm. Awesome. Thank you. Thank you, Dr. Blue, for joining us there. I know you got to run off to get your flight there, but thank you. Thank you
Yes.
for the questions,
All right,
everyone.
guys.
And
Take care.
we're going to try to
Thank you
get
so much
this
for the
rest of
invitation.
these questions answered too there. Thanks, Dr. Blue. Safe travels to you. All righty. So next we have Dr. Monique Hartley Brown. She's going to be presenting. Dr. Hartley Brown, the floor is yours.
Thanks so much, Valerie. Thanks for having me as usual. Always a pleasure on my end. Let me see if I can figure out how to get this thing started. No. Oh, here's a little. Okay. So Dr. Blue went through quite a lot of information. I am going to try to look at things from a slightly different angle. And so, last year I talked a bit about monoclonal gammopathy of undetermined significance, which is we basically kind of shortened that into MGUS. And then I also talked a bit about smoldering multiple myeloma as well as active myeloma. And I'm going to review some of the data from last year that we talked about, just as a reminder, and then go into some updates. Ah, it is not moving. Why are we not moving? Can you see my screen?
Yeah, I can see the title slide there.
But it doesn't seem to want to. Oh, there we go.
Oh,
Sorry.
there it is. It's moving now.
Okay, so these are my disclosures, and I'll give it a couple of seconds there for review. Okay, so reviewing a few things. What is MGUS and what is multiple myeloma, whether it's smoldering or active? And what are risk factors that are associated with both? I think Dr. Blue went into some of this information earlier. Multiple myeloma is a type of blood cancer. So the particular cells that become cancer cells are plasma cells, and they live in the bone marrow normally. And so plasma cells are actually a part of your immune system. They are a type of B cells that are much more mature, and they make antibodies. So when you go and you get your vaccines, or you go and you have had exposure to certain types of bacteria or viruses, your body is able to remember that, and your body is able to make antibodies to stick to those pathogens or stick to those diseases that should not be in your body, and allow your immune system to recognize that they're foreign particles that should not be there, and your body will kill these germs. Now, when the plasma cells become cancer cells, they don't work the way that they should. So normal plasma cells make healthy antibodies to fight infections and to protect you from infections, because not only do they fight infections, but they also survey and will highlight infections or potential infections that are coming. And when those cells become cancer cells, they make excess amount of antibodies that don't function. They don't look normal, and they don't function normally, and they grow and multiply out of control. And so because they typically live in the bone marrow, we will see a lot of these cells living in the bone marrow when we do a bone marrow biopsy. Now, what is a sequela that comes from that? The sequela that comes from that is a whole list of things. I'll go into that some more. But what would increase your chance of your healthy cells develop into cancer cells, specifically plasma cells developing into multiple myeloma? Older age increases your chance that your body is not doing the checks and balances that it should be doing, and so your immune system is not working the way it should, and cancer cells are likely to develop more in older people than in younger people. We have seen some studies showing that weight has something to do with it in terms of patients or people who are overweight. There is an association with increased disbalance or imbalance in the immune system, and a lot of inflammatory markers which are increased within the body that increases the risk of developing cancer. For multiple myeloma, there's a slightly increased risk of males than females developing this disease. Not quite 2 to 1, but a little, maybe 1 and 2/3. Family history, that is very important. So for any of us who have a first degree relative, and by first degree, that means someone who is mother, father, sister, brother, daughter, son. So essentially someone who is just 1 degree away from you. If they have a history of multiple myeloma or amyloidosis, which is a disease that's very similar to multiple myeloma because it arises from the same cells malfunctioning, then those individuals are at a higher risk. And then, as I mentioned before, inflammation within the body increases risk. So Dr. Blue mentioned that there are other hematologic malignancies that come along when you get older, or other triggers for that. Yes, multiple myeloma, if you develop other malignancies, you've been treated for other malignancies, or you have an increased kind of baseline inflammatory conditions such as autoimmune diseases, for example, your risk of developing this particular malignancy is increased. And then the unique phenomenon that we've also noticed is that individuals of African American ancestry are at higher risk of developing this disease. And I'll go a little bit into that further on. So when we think about monoclonal gammopathy of undetermined significance, we're talking about MGUS. And I showed this slide last year because it is a quintessential slide that shows that, you know, this is a finding that we see in patients that seem to be healthy. However, it is not to be ignored, because there's at least 3% of the population under the age of 50 or below, that may have this condition. And this condition also increases with age. And the unique portion of it is it's 3 times more common in African Americans or people of Afro descent than it is for whites. It's also 3 times more common in familial cases. So remember, I alluded to individuals who have a first-degree relative with myeloma or amyloid. They are much more likely, 3 times more likely, to have MGUS than the average individual. And then the other thing that we pointed out earlier, and I think Dr. Blue may have mentioned it as well, is individuals of Afro descent, and I'm going to use Afro descent as opposed to African Americans, because Afro descent covers individuals that are of Caribbean background, of African background, of American background, and so forth, and Latina. Or Latinx. So much broader coverage with that term, because we do have a much more increased evidence of MGUS in these populations. And therefore, MGUS is actually a pre-malignant condition. What do I mean by pre-malignant? It is a condition that, even though patients don't find that they have any symptoms, and the clinicians or providers don't find there's any actual evidence of damage to any organs in the body, this is something that is more common in Blacks than whites, and is actually something that we typically will see before an individual develops multiple myeloma. So it's a precursor condition to developing multiple myeloma. And there is a 2 to 3 times higher incidence of MGUS and smoldering myeloma in those individuals who have active disease or who develop active disease. We also see this younger age, and for Afro descent individuals, it's about 5 years younger. So the average age of developing multiple myeloma, or being diagnosed, I should say, with multiple myeloma, is in the late 60s, so around 67, 68 years of age. But when you look at Afro descent individuals, specifically Blacks in the US, and Hispanics, for Hispanics, it could be anywhere, it could be as low as 10 years younger. And then for Afro descent or African Americans, it could be as young as 5 years. And the concern that we have in this country is there are poor outcomes for these individuals despite the stage of disease. So in refreshing your memory of last discussion in 2024, the incidence rates are higher in African Americans for multiple myeloma than in whites. So we're looking at numbers that are about 2 times higher. So 15.9 versus 7.5 cases per 100,000 respectively. And then again, we see that duplicate number of mortality, 2 times higher mortality, a little bit more than 2 times actually, higher mortality in African Americans than whites. And then this is old data from SEER, and I apologize because I'm just noticing that on the screen, my reference is superimposed on the data, but the SEER information just essentially confirms that there is a higher predominance of this mortality rate than in African Americans. Now, what is the difference between MGUS, smoldering myeloma, and multiple myeloma? I like to define the difference between smoldering and active myeloma because that active word kind of helps to define a little bit more what we're seeing. So MGUS, essentially, we see an elevated protein in the blood. Okay, so that protein is actually a reflection of those antibodies that those plasma cells are making, and they're higher in the blood in these patients who are African American patients. In patients who have MGUS. Apologies there. The clonal plasma cells in the bone marrow, that requires a bone marrow biopsy, and when we do the bone marrow biopsy, for a normal individual who does not have multiple myeloma, we should see plasma cells in the range of 5 to 10%. Anything beyond 10% suggests MGUS or some other disorder along this plane. Okay, MGUS shows no myeloma defining events. And by that, we'll go into what that means further in this slide, but smoldering myeloma, more than 3 grams of this protein that's spilling into the blood or in the urine. And those plasma cells, when we look at the bone marrow under the microscope, we see that more than 10% of those bone marrow cells are these plasma cells. And it can go as high as up to 60%. And there's still no myeloma defining events. So I want to define what that means. So myeloma defining events includes what's in that red circle below, the CRAB criteria, elevated calcium levels in the blood, kidney problems or evidence of renal insufficiency, anemia, meaning the red blood cell amount in the blood is lower than it should be. And specifically, we have cutoffs of about 10 grams or a hemoglobin of 10 or below. And just for reference sake, for an average female, an hemoglobin level of about 12 grams per deciliter is normal. For an average male, 13 to 14 or above 14 may be normal. Bone disease, meaning damage to the bones, unexpected or unprovoked fractures, or thinning of the bones, or these lytic lesions where we see that the bone area is thinned out. Now, when we talk about active myeloma, those myeloma defining events, 1, 2, 3, any number of them are present, but also we see a clonal plasma cell or plasma cells in the bone marrow of more than 60%. That can be a defining feature of multiple myeloma. Or we have active CRAB features that I was just describing, with greater than 10% plasma cells in the bone marrow. The other thing, sometimes the protein that is created by these cells are light chain proteins. So they're not necessarily that protein that you will be able to measure in the blood, which is what we call that M protein. Sometimes you can measure it better on the specialized test called the serum-free light chain testing, or you can measure it in the urine because these are smaller proteins, and sometimes those are the proteins that are being produced by these abnormal plasma cells. And if those cells are in abundance, so the abnormal cells are more than 100 times what they should be, then that's a defining event for multiple myeloma. And also on scans, looking at the bones, if you do an MRI of the body, or if you do CT scans, specifically an MRI showing a lesion in the bone that is thinning of the bone or damage to the bone in some way that is greater than 5 millimeters, that can also be considered a myeloma defining event. Shifting gears, we did touch on the fact that there is several staging systems for multiple myeloma. So when we look at the original There's been a few staging systems to begin with. The most common one that's currently used is the revised international staging system, which describes what I went through just above. However, there is an R2 revised second international staging system, which incorporates some genetic changes that we've noticed. And I think that was touched on in one of the questions before, which shows that when we see this genetic change of chromosome 1, a portion of chromosome 1 having extra copies in the Q arm of the chromosome, and we see 3 copies of that 1Q or amplification of that 1Q, that can indicate a poor prognostic feature. And that was added in for the second revised ISS staging. Now I'm pivoting here into just identifying that when we talk about MGUS, some of the things that we're doing is looking into what does that mean, and how do we best kind of look at patients who are at high risk for MGUS and potentially prevent them from going on to developing multiple myeloma. So there's a lot of studies that are coming out of this. The PROMISE study is one of the bigger studies in the United States. And essentially, if you fall into that category of having a first-degree relative with multiple myeloma, or you are of Afro descent, you would be eligible over the age of 30 for just screening. It's a screening test. You feel healthy, you have no symptoms, but you sign up for this test. It's easy, it's online, and it can help to give you some further information about what your risk is for MGUS and what that means for you as an individual. We also have other things, including P-Crowd, which is also for patients with high-risk disease. So if you have a relative who already is diagnosed with active multiple myeloma, that individual would be a candidate for further testing in the P-Crowd era, or their relative would be a participant as well. Now, moving on, what are some of the newer findings of MGUS? So I did a nice little review there of what we talked about last year, and how things are moving forward is really what I want to touch on here. Now, there's a lot of movement happening, so I'm trying to be mindful in how I touch base on what might be considered important to you. So we talked about the definition of MGUS, so I'm not going to go over that, but I do want to mention that just the same way that multiple myeloma has poor prognostic risk factors like the 1Q, each section of this progression is risk stratified. So MGUS has a risk stratification, and we do consider MGUS to be in a low risk category, intermediate risk category, and high risk category. That really, for the most part, depends on what the level of the tumor burden is. So how many plasma cells we actually see on that bone marrow biopsy, and are there any genetic changes in those plasma cells that correspond or correlate to what we oftentimes see in multiple myeloma. The reality is we don't, in the standard treatment setting, have any defined recommendations of treatment for MGUS overall. It's more of an active monitoring and surveillance. However, the individuals who have a higher amount of plasma cells that are in the bone marrow are more likely to fall in the higher risk category. There are also categories that consider the type of protein that the plasma cells are creating, so IgM or non-IgM, and then the light chain MGUS, as I alluded to earlier, those smaller proteins that can be produced. And there's only two of them. It's usually kappa or lambda for the light chain. There are several risk score models. It's not quite standardized. And so, we are still working on research to try to fully determine how best to categorize and standardize risk stratification for MGUS and also for smoldering multiple myeloma. The key things I would want you to take from this slide is the high risk changes that I've been talking about include things such as translocation 414, which is where chromosome 4 and chromosome 14 switch a piece of them to each other, and it kind of turns on certain genetic features that allow for rapid production of these abnormal cells. Similarly, translocation 1416, and then that gain of chromosome 1q we talked about, and also highlighting deletion of chromosome 17p. So again, chromosome 17, there's the P portion of the chromosome and the Q portion, and there's a section on P that if there's a deletion of that, it's literally kind of, saying, hey, there's no limits, keep going, keep multiplying, but it's telling the cells to keep multiplying abnormal cells. Okay, so these are important chromosomal abnormalities or cytogenetic changes that we talk about in this disease. What are some of the modifiable risk factors that we've learned about in the past few years if we're thinking about updates for MGUS? So I'm going to mention this because we talked about the PROMISE trial, and out of the PROMISE trial, there was a study that was done with over 2,000 individuals, almost, 28, so 2,628 individuals, looking at those patients that they defined as high-risk MGUS. And they did an additional screening test by mass spectrometry, that looked at these cells. Now, normally when you check for MGUS, you don't typically do mass spectrometry, but in this case, this is a study, it's a trial, and they looked at these actual samples from all these patients who were volunteering to give these samples. And they found that based on mass spectrometry, the MGUS that they saw, there were certain individuals that kind of fell into this high risk category. And they compared those samples to, the information that was gleaned from the volunteers. So, do they fall into a normal weight? What is the BMI of the individual? They adjusted for age, sex, race, education, and income. They looked at the physical activity that was reported, as well as smoking and sleep habits. And, it seems like there is an increased association of high-risk MGUS with a higher BMI, with obesity, with less physical activity, with increased smoking, with less sleep, which is suggesting that these modifiable day-to-day things that we can potentially change are associated with this pre-malignant condition. Shifting gears, thinking about smoldering multiple myeloma, we also have seen quite a few information coming out lately about treatment of patients with multiple myeloma, even in the early stages of smoldering. So just to remind you, smoldering multiple myeloma is we have measurable protein in the blood, we have elevated levels of plasma cells, more than in MGUS, but not quite fitting the diagnostic features for myeloma. And we also do not have any evidence. We do not have any evidence of problems within the body or organ failure. But many of these patients much more likely to develop multiple myeloma than they are than the patients who have MGUS. And so what that means is maybe we could potentially treat things early. If you think of the quintessential example I would use is for patients with early stage breast cancer. If you have, encased ductal carcinoma in situ, we do things for that. We do mammograms, we do screening tests, we treat that condition. And so potentially there's room here if we have a patient with smoldering multiple myeloma, especially if they're high risk, maybe we can potentially cure some of these individuals. That is the thought. And so there was a big study that came out and got published last year, looking at use of daratumumab versus active observation in these patients who have smoldering multiple myeloma. It was over 390 patients in total. And when we looked at the groups, pretty evenly split, 194 to 196, those individuals who actually got treated with daratumumab as a single agent had a longer time for their disease to progress. And so we had a median follow-up of about 65 months. And there was a much lower chance of those who were exposed to daratumumab to progress in terms of their disease. And so this is something that is very, very significant because I think there's a lot of thought around how can we treat individuals who are at high risk but do not have symptoms to prevent damage to their organs when they do actually develop active disease. Now, the caveat with that is we still have to think about what that means in terms of adverse side effects of the medication that is being given to these patients who are essentially asymptomatic. Out of our institution, we have quite a few studies, and they're looking at some of the cutting edge treatments that we use these days. So, specific patients looking at high risk smoldering myeloma and use of CAR T therapy in those patients. Again, this is a clinical trial. This is something that is a voluntary situation and is discussed with the patient. So we do have a lot of patients who are very strong advocates for trying to eradicate anything that could progress into an incurable cancer. And so we do have patients who are part of the study. We also have daratumumab use in early use of daratumumab in combination with Revlimid, Velcade, and dexamethasone for a fixed duration for some patients. And then we also see use of bispecifics, specifically in this phase 2 clinical trial. It was teclistamab in combination with Revlimid for patients treated with high-risk smoldering myeloma. And in the interest of time, I can't really go into all the depth of detail, but lots of provocative information here suggesting that we could do a lot in terms of delaying the development or progression of high-risk smoldering myeloma to active myeloma for many of our patients. Now, some of the older data that I wanted to remind you of is looking at the VA system. So if you think back to the earlier slides, I talked about the fact that, patients of Afro descent in this country had worse outcomes. And the question is, well, why? And so when we looked at the VA system where patients are essentially treated similarly, right? They're all veterans, they all come in, they all see the same group of individuals, and they kind of get the same treatment. When you look back at that information, those patients, the African American patients, actually did as well as their white counterparts, or even better. And that makes sense, especially knowing that there's information that shows that African American patients or patients of Afro descent are more likely to have standard risk features of their myeloma than their white counterparts. So I wanted to remind you of that because some of the updates on what we've seen in genetic mutation research in our African American patients, still again, real world data and kind of retrospective data, I should say, is showing that when we look kind of Puri and colleagues, oh dear, again, it's sticking. Why is it sticking? Oops. Okay. When we look at these colleagues and we look at 19 global trials with several patients across the globe, so over 10,000 patients, pooled data, we don't see a lot of African American or Afro descent patients included in clinical trials. So if you break it down to white, Asian, Black patients, 84% white, 7% Asian, 4% Black in the database. Hispanic patients, 4%. And so, what do we do with this information? We see this chart and we see, okay, overall survival by race. If you look at chart A, it looks like the Black patients are doing better. But if you look at the numbers, there's so much less of them. So can we really utilize that information readily? Because we're not actually reflecting the population at large. So the population in the US of African American patients with multiple myeloma is encroaching 25%. So how can we use 4% to be a representation of this patient population? I don't think that's appropriate. So this is something that we have a lot of work to do. Okay, again, in the interest of time, there is a lot of treatment that is newly available, that is coming out. We touched on CAR-T, we touched on bispecific therapy. I didn't hear much talked about cereblon modulators, but there's a lot of novel therapy that's coming off the shelf. We have BCMA targeted therapy, antibody drug conjugate therapy. We had one that was approved, belantamab mafodotin was approved, and then had an early approval, and then the conditional approval reason it was withdrawn, but potentially we will hear more about this medication because there's some positive clinical trials that came out with that. But in the interest of time, I'm going to focus on the quadruplet therapy because I remember someone saying in the question, and what's happening with certain populations and whether they're getting the appropriate treatment up front. And I would preface that with saying we've looked at before quadruplet therapy, triplet therapy, and transplant. And what we did see was that patients of Afro descent in this country were not getting optimal therapy up front as one would expect. So triplet therapy and transplant therapy was less likely to happen in the patients of Afro descent. And so now we're dealing with quadruplet therapy, which has recently been approved by the FDA. Given some of the clinical trials that read out in the past year. And so the first one I want to touch on is the Perseus trial. I don't even see the title popping up, and maybe that's my fault. But the Perseus trial, many of you might be aware of the Griffin trial, which was a phase 2 trial. The Perseus trial was a phase 3 trial. And this was practice changing. And it looked at that quintessential Revlimid or lenalidomide, as we say, bortezomib and dexamethasone triplet combination combined with daratumumab, which is a monoclonal antibody to CD38, which is a protein found on the myeloma cell specifically. And it hones in on that target, goes after it, and helps to kill those cells. So there is the quadruplet therapy versus the triplet therapy, and these patients were transplant eligible because if the patient is healthy enough and appropriate enough and eligible for transplant in the newly diagnosed setting, they would be offered transplant. And that's a historical situation when it comes to multiple myeloma. And so in this trial, after transplant, everyone in the quadruplet arm still got the daratumumab throughout the trial. And so the consolidation was still a quadruplet therapy for more cycles, as you can see here. And then for the maintenance portion of it, instead of it being Revlimid only, it was daratumumab and Revlimid for portion of the time. And then if the patients became MRD negative, and again, MRD being minimal residual disease negative, so as deep as we can measure, no evidence of disease, then you de-escalated therapy to just Revlimid alone, versus if MRD positive, you kept that daratumumab. Whereas the triplet therapy kept going with triplet for consolidation and then switched to Revlimid as the maintenance. And then this particular study really reflect, oh dear, again, not moving. Why aren't you moving? There we go. So this particular study really reflected what we saw in the Griffin. So you repeat and you see the same results, and you know you are on the right track. And so what we saw with this particular trial, which was published back in 2023, at least the early portion of the was published in 2023. There's some full publications subsequent to that. But after 48 months, the progression-free survival in the quadruplet arm was 84%, and in the triplet arm, it was 68%. So we are seeing a clear difference in outcome. And the things that I can't show you on the slide, and due to the interest of time, is that did much better in terms of the toxicity was not significantly higher in the quadruplet arm compared to the triplet. Similarly, for those patients who were not considered transplant eligible, we looked at another agent, isatuximab, in the setting of the quadruplets. So same backbone of VRD, but isatuximab instead of daratumumab. Again, you can see the design here, and you can see how many patients, a little bit different design, 3-2 in terms of the randomization, but the outcome favored the quadruplet. And you can see the splitting of the curves, 60-month progression-free survival of 63% versus 45%. Okay, so just because we don't have as much time as I would have loved to talk about, because this is a lovely area of interest of mine, but we need to talk about, okay, so how do we improve and how do we change and do things that would improve the outcomes for patients who are, one, as I mentioned before, not well represented in clinical trials, two, having worse outcomes despite the fact that they have standard risk disease. And what are the things that are affecting these patients? Like, how do we improve upon these patients' survival outcomes and treatment outcomes overall? And so we have to look at things like social determinants of health. I think location is a big thing. Policy, I'm going to refrain from getting too in depth on that because we know what's happening in our country today, and that could stem a whole list of wormholes that I'm not going to go down and I don't have time to discuss. But more importantly, this is a team effort. It's not just the patient, it's not just the provider, it's not just the healthcare system. It's going to take all of us to work on this. We all have to have work to contribute to this. When we think of the social determinants of health, for those of you who are not quite sure what that term means, it is a very broad term that includes things like health literacy, education, what's the level of education of the patient and their family and the situation that's going on, income. Are these individuals in a space of food insecurity or food deserts? Housing insecurity. What are the environmental risk factors? One of the risk factors I did not get a chance to go much into is pollution and exposure to carcinogens that increase your risk for cancer. So if you live in environments that increase that risk factor, or you are working in those types of environments, your risk for developing cancer, including multiple myeloma, is increased. Psychosocial stressors. Insurance, not all insurance are created equal. There are individuals who are not insured or underinsured, and we need to be mindful of that and all the changes that are about to come. And then the other healthcare related financial distress that may affect patients depending on where and what categories they fall into. So very convoluted, very intense, and in the interest of the time that we have available, cannot do a deep dive in this. This could be a talk in and of itself. But I'm thinking that we have a lot of work to do in this space. And Dr. Botani, myself, Dr. McHale, and others have put out information about this. When we also think about other things that might affect this process, really, you know, financial barriers are a big issue. When we talk about insurance are not created equal, that means out-of-pocket costs for individuals are going to be different. Black patients are at higher risk for non-drug related costs and hospitalization. So not only talking about the actual cost of the drug itself, but what that means in terms of missing days at work, or you know, having a broken bone and having to be hospitalized, things like that. So when we look at this, this gives you a objective view of what that means. So individuals who are treated with double class exposed means two different types of therapies. So for example, proteasome inhibitors and an immunomodulatory drug like lenalidomide. That cost is much lower than triple class exposed. So those individuals who were treated with, for example, proteasome inhibitor, monoclonal antibody, and steroids, and you know, administration of those costs, and not just in, most of these costs are outpatient, like most of these myeloma treatments are given in the clinic. And you can see that from the diagram, that the outpatient costs are one thing, the administration costs are another thing, and the actual treatments costs are another thing. So we have to think about that, because these costs are increasing, especially considering that this is an incurable disease and patients are on treatment for a very extended period of time. Other things we have to be mindful of. Bias exists. Okay. I don't deny that I am biased in one way or the other, because I'm human. People are people, and we all have biases. It helps to be open and mindful of the fact that you may not be able to see all your biases, but the ones that you do see, recognize them and try to improve upon them in terms of patient care. So clinician willingness to understand and address implicit bias. Understanding that a lot of these false narratives about individuals of Afro descent in this country stem from bias and include misconceptions about their willingness to get treatment, their pain tolerance, their adherence to treatment. Pain tolerance is big key, especially in a disease like multiple myeloma, where patients could have fractures, very painful fractures, debilitating fractures. And ensuring that every patient's value is incorporated in that discussion making and partnership that goes along with caring for that individual, and recognizing that overcoming these biases and misconceptions really goes a far way in terms of the patient's experience and thoroughness in going through with their treatment. And then recognizing every culture is different. People are people. We all have our different beliefs, and being respectful and mindful of that within your interaction with individuals. It does help if it's a healthcare system that has individual of staff from all different cultural backgrounds. But, reality is sometimes somebody's going to walk through the door and we may not have that interpreter available for their language that's in person. But maybe we can do that on a video interpretation or so forth, as an example. So being mindful of cultural differences and how we can best educate and respect people of other cultural backgrounds, spiritual backgrounds, etc., is important. So again, going back to the thought, it's going to take the entire village, and the village is global, and it requires not just the patient and the provider, but the entire team, the nurses, the phlebotomists, the navigators, the everyone. And patients, I would say this is a patient platform. Advocate for yourselves and be vocal about what your needs are, especially when it comes to subjective things that providers cannot facilitate unless you actually provide them with that information. Pain being the quintessential example, because my pain you can't see. But if I'm telling you as a provider that I am in significant pain, then I would hope that you as a provider would listen and understand and try to help in that process. So with that, this is also just kind of a broad screen here about transplantation. We still utilize transplant in multiple myeloma. There's still a lot of data, as Dr. Blue talked about, that is forthcoming, looking at what that means in the new world that is developing in terms of CAR T versus transplant. Do we need transplant? But right now, transplant is still important. And we are still seeing that patients Black patients were less likely to receive transplant in first line of therapy, even if they were eligible, and that affected their progression-free survival significantly. So with that, I am going to stop here and say thank you very much for listening, and I really appreciate having this opportunity to be here today.
Thank you, Dr. Hartley Brown. Awesome presentation on MGUS and smoldering myeloma. I want to try to get to as many questions as we possibly can, but I want to just touch bases on something that you just said, that the Black patients are not having the stem cell transplant even when they're eligible. Why do you think that is? What is the, what is the data showing on that? Why are we just not taking advantage of those when we are transplant eligible?
So I don't think it's just secondary to patients not taking advantage of it. I think, when it comes to multiple myeloma, as you know, the sooner you see a specialist, the better. And that part is key, because not all centers are equipped for doing transplantation. So if that conversation is not brought up early, a patient starts on therapy and they're probably thinking, okay, I just have to go through this and I'll be fine. And then they get sideswiped later on saying, oh, well, you are eligible for transplant. We should consider that. You need to drive 200 miles away and stay in that hospital down there for 3 weeks, et cetera, and all the things that come along with it. That is a bit jarring, because you're not prepared for that, right? And there's a window of time. If you're considering doing early transplantation for an individual, you want to have that conversation early on, usually newly diagnosed, so that it's understood what that means. Transplant, like CAR T therapy, for example, it comes along with more than just getting therapy. You may need to stay in the hospital or nearby that hospital that provides the therapy for an extended period of time, which could be weeks. That could mean needing to have a person who will help you with that process, etc. That could mean hours away from your job, which could affect your income. It could mean a lot of things. So that discussion, the earlier on it's had, the better prepared that individual is. And I think a lot of the discussions that need to be had early in the diagnosis of myeloma may be somewhat of a barrier, because they don't happen that early. And it's not just from the patient's side. I think, we shouldn't lean on the patient automatically knowing. We should lean on everybody kind of coming together and having that discussion early.
I agree. Thanks for saying. This was a very good question that came up in the chat. Should people of color be asking for specific myeloma testing? And if so, what is that testing?
I think I think that just based on the information that we know, if you are a person of color, Afro descent, Hispanic, it is worth looking into things like the PROMISE trial, or looking into just talking to your provider about what you found out and what types of things you're concerned about. So for multiple myeloma, we typically do not screen for multiple myeloma. That said, that's why I bring up the PROMISE trial, because that's a clinical trial that you can no out-of-pocket cost to you as an individual, but you are technically being screened for this. The second thing I would say is, if you have a provider that you trust and has been working with you for however long, that individual you could talk to, and you could say to them, well, I've heard about this, that, and the other, and that provider, knowing about MGUS, could potentially, off the record, screen you and do a serum protein electrophoresis panel, or a serum free light chain panel, in the event that they're seeing something abnormal on the comprehensive metabolic panel. So the comprehensive metabolic panel is usually a part of what gets done when your primary care does their regular screening once a year checkup type deal. And the key component of that is going to be the electrolytes and the total protein that comes up on that test, and your kidney function. Those things can be very telling. So the total protein is elevated, or the kidney function markers are abnormal. That might be something to prompt doing the serum protein electrophoresis and the serum free light chain testing.
Thank you for that. So this is a good question here. If you were diagnosed with MGUS earlier on, would there be something you could do to make sure it doesn't go into full-blown myeloma, or at least slow it down significantly?
So we're still working on that. So one of the updates that I talked about is those modifiable risk factors. And, we talked about obesity, we talked about, smoking and things like that. Those are some of the risk factors that they suggest that they are related to not just myeloma, actually, but many other cancers, if you look across the board. And so I think that those are things that we're finding we could potentially do things about to try to improve outcomes. That being said, there's still a lot we don't know about MGUS, and a lot we don't know about what triggers MGUS into becoming active multiple myeloma, because MGUS can be a precursor for other things. And there's still some people who, with MGUS, it's a small group, but they're present, and they don't actually develop multiple myeloma in their lifetime. So we still have a lot of work to do on that end.
Thank you. Thank you for that. And I want to go back when you were talking about the chromosomal abnormalities. One that I know is P53. Can you speak on that one a little bit? Because I know that it tends to affect African American population a little bit greater than others as well. Can you talk on that one?
So P53, what I talked about was that we see that more in, if you compare the data that we do have, we're likely to see an increased evidence of P53 in non-Blacks, so white patients than Black patients. That being said, it is a deletion. So it's removing a control, right? Our genetics, our body is fascinating, and our cells have things in place that limit multiplication and division of abnormal cells. Like, our body is wired to kill those cells that should not go forth and live further, because those cells are behaving badly. When those signals get turned off, for example, with this deletion, then it can cause rapid growth of these cancer cells. And the thing about deletion P53 is we see that in multiple cancers. So it's not just specific to multiple myeloma. But even in those other cancers, it is and it essentially is kind of removing that signal to the body that this is a bad cell that is rapidly dividing. In multiple myeloma, what that means is we can treat you, but when we treat you, a lot of these individuals with this particular genetic mutation, they get the treatment and then their cancer comes back very quickly. So instead of lasting 4 or 5 years with the cancer under control, within months, the cancer comes back and it's active, and we have to do something else, and we have to do something else. And so within a short period of time, we're going through multiple treatments because the cancer just, it finds a way to evade the treatments that are given.
Another good question is, how would you know if your MGUS is progressing? Since my doctor tells me that my levels are within the range, however, I've had more bone pain, my immune system is compromised, and I can barely function. With being the last, few months have been kind of hard for this individual there. So how can an individual tell, if they do have MGUS, that is the disease is progressing?
That's a very good question. So again, we're still learning a lot about MGUS. There is emerging information about, things that may not have been noticed as symptoms of MGUS. Neuropathy, for example, numbness, tingling, or different sensations in the limbs, fatigue, so we are still learning a lot about MGUS. And I would say that if you definitely have a diagnosis of MGUS, we still need to follow you. Like, you still need to be followed closely by a hematologist, oncologist. You still need to have routine checks on that protein. So if you have a measurable protein in the blood or a measurable protein in the urine, that protein needs to be measured every few months, depending on if you're high risk. High risk, we usually do at least every 3 months or 3 to 4 months. Lower risk, maybe like once a year, and intermediate, maybe like 6 months. But the point is, you need to be monitored. And not only is that protein followed, but clinically you need to be seen, you need to be examined. And then your part in that conversation is what's changed in your day-to-day function, and whether you feel like there's some changes in your body that doesn't make sense, right? Doesn't kind of add up. And then finally, the other thing is the routine stuff, right? CBC, checking to make sure that your complete blood count is normal or at your normal baseline, based on your medical history, and then that your complete metabolic panel is at your normal baseline. Because if there's any signs of end organ damage or changes in your body that are not adding up, then maybe this MGUS is not just MGUS anymore.
For that. And then we have another question. This individual says that they are seeing more and more men that are dealing with prostate cancer. Is there a connection? I think the same thing when it comes to breast cancer. Are we seeing a connection when it comes to those two diseases? Because oftentimes there are patients that will have a diagnosis of myeloma and then have prostate cancer or breast cancer, or vice versa, have one of those solid tumor cancers and then get multiple myeloma. Is there any data or research in those connections there?
I'm going to apologize in advance because I do have to hop off. It's 3:40, almost 3:40, but I will say in answer to this question, I do think that there is a potential relationship between endocrine cancers. I use that term, endocrine cancers, because breast cancer and prostate cancer are typically associated with your, testosterone for prostate and and estrogen for breast cancer, right? So they're very often related to your hormone levels, and the hormone levels and the hormone system in the body is tightly linked to your inflammatory state and your immune system. And I do see more and more, anecdotally, I have not done a formal analysis of this, but I do see more and more that patients who have had a history of breast cancer, even in the status of not receiving chemotherapy or other therapies that might increase your risk for developing other malignancies, developing multiple myeloma or precursor state. And I do think that that is potentially linked. I think there's further information that we need to look into on that, because maybe it'll be helpful. Maybe we'll find something in terms of, dual screening or ways we can, identify people that are increased risk, who may have breast or prostate cancer. But again, still early to state that.
Thank you. Thank you, Dr. Hartley Brown, for joining us. And we'll wrap up. I do know you have to go. To any closing remarks, Dr. Hartley Brown?
Thank you for having me. I think this is a great forum, and I'm happy to answer questions offline. And again, I think, we really need to work together as a team, all of us, patients, your loved ones, your family, the entire healthcare system. And we have quite an uphill battle at this moment, but we can do it. So
Thank you.
thank you.
Well, make sure that you join us back here next month on March 27th. We'll be hearing from naturopathic Dr. Michael Walker. He's going to be discussing some of the ways to manage the side effects that you're dealing with, that you may be dealing with as you go through treatment. If you haven't had an opportunity, make sure you check out the blackmyelomahealth.org website. And just a few upcoming events that I wanted to notate about. On Monday, March 3rd, we're having the Tech Innovation doing Myeloma Awareness Month. Everybody knows Myeloma Awareness Month starts, it's in March. So that's the kickoff there. And then on Tuesday, March 4th, the Myeloma Podcast, Preventing Myeloma Progression with Diet. It's going to be part of the Nutrivention 2 study. They're going to go over that. And then also on Tuesday, March 4th, Navigating Financial Uncertainty, Proactive Tips for Blood Cancer Patients and Families. As always, I want to thank our sponsors, without whom this event would not have been possible. Adaptive, AbbVie, Genentech, Johnson & Johnson, Pfizer, Regeneron, and Sanofi. And finally, I want to thank you all for helping us grow a strong multiple myeloma community. I've added my email to the end of the slide. Don't hesitate to reach out if you have any questions about HealthTree or any of our programs. I appreciate you all and hope that you enjoy the rest of your day and look forward to seeing you on a webinar